We're back, and in this set of video lectures, again, we'll be discussing how to code neoplasms or cancer. Note that all these codes begin with the letter C and go all the way through D49. We'll talk about some main terms or key terms. And again, this can be a little bit heady, a lot of terms. You'll need to know some morphological terms. And as a result, extra time to know some of these may be required. A lot of success with coding these things requires paying attention to the definitions and details that are in the guidelines. So we'll cover that as well. So as we talked about, malignant neoplasms or ones assumed to be primary, in other words, the first site of the cancer, and certain histologies, except for neuroendocrine and lymphoid, hematopoietic, and related tissues, are all going to be coded from C00 through C75. Neuroendocrine tumors that are primary will be coded with C7A. If they are secondary neuroendocrine tumors, in other words, metastases, they will be coded with C7B. C80 covers ill-defined or other metastases and unspecified sites, and C81 through C96, those codes are reserved for malignant neoplasms of lymphoid, hematopoietic, and related tissues. If we have something that is in situ, which is a term that you'll see commonly when referring to cancer, it is in D00 through D09. And the D10 through D36 is benign neoplasms, with the exception of the benign neuroendocrine tumors. D3A is for those benign neuroendocrine tumors, and D37 through D48, neoplasms of uncertain behavior, including such things as polycythemia vera and myelodysplastic syndromes. And then D49 are tumors of any unspecified behavior. When we talk about behavior, neoplasm behavior, we're talking about definitions of the malignancy. In other words, is it primary? Is it secondary? Or is it carcinoma in situ? Neoplasms we always associate with cancer, but they can be benign. They can also be uncertain behavior or unspecified behavior. So pay special attention and look for these terms as you read these encounters. When we talk about carcinoma that's in situ, we're talking about abnormal tissue cells that are in the inner tissue layer. Carcinoma or cancer tumor is composed of abnormal cells, but one of the behaviors it has is it spreads into nearby local tissue. This could be connective tissue, muscle, and other layers. There are a lot of guidelines, and it would really be worth your time to spend some time looking at these guidelines for neoplasm coding. There are some general guidelines, and that would mean that you reference the neoplasm table first. If there's a histological term, such as OMA, right, a term with OMA in it, that term may be referenced in the alphabetic index first. Many students, as they're learning how to code these, start with the neoplasm table and then move on and go to the alphabetic index as needed. There are specific guidelines for coding and sequencing any complications. Primary malignancy that was previously surgically excised. There are guidelines on admissions or encounters involving chemo, immunotherapy, and radiation therapy. and admissions to determine the extent of a malignancy. Also in the guidelines are covered signs, symptoms, abnormal findings, malignancy that's in 2 or more contiguous sites, disseminated malignant neoplasm unspecified, and any malignant neoplasm without specification of site. Again, the whole key is to reading and understanding the guidelines, and these are very nicely summarized in your text. There are guidelines, again, as we talked about, for how you sequence things. Frequently, patients will not only have a primary, but a secondary. Sometimes we have patients that have a neoplasm and they're pregnant. We have complications with neoplasms. We can also have complications from the surgical procedure or treatment. And then finally, we can also have pathological fractures due to neoplasms. One of the things that becomes very important is we always think of cancer as something that never goes away. It just goes into remission. But remember, we don't code cancer at a microscopic level. We code these things based on what the documentation and the guidelines say. So if we have a current malignancy, say somebody has colon cancer, it's surgically excised with clear margins. They don't have any symptoms, right? That is a personal history of the cancer, right? And we also have involved guidelines for the soft cell cancers. These include such things as leukemia, multiple myeloma, and malignant plasma cells. And then finally, we have guidelines about aftercare. So again, big part of success in coding these conditions is paying close attention to the guidelines. And more on guidelines that I'll let you read here. And now we're going to jump into the neoplasm table. Turn to the neoplasm table in your book, and we will take a closer look at it and go through this. The next set of video lectures will cover how we can use the neoplasm table to find the correct cancer code. We'll see you then.